Good morning, and welcome to the fifth of our series of web-based seminars on best practices in tuberculosis control. Today's seminar will focus on working effectively with diverse populations. That is, cultural competency and communication, but reaching to people who may be outside of cultural groups with whom we're accustomed to thinking. My name is Bill Bauer, and I'm Director of Education and Training at the Charles P. Felton National Tuberculosis Center, a component of the Northeastern Regional Training and Medical Consultation Consortium at the New Jersey Medical School. Today's program is sponsored by the consortium. The objectives for the seminar are that you will be able to explain how cultural factors influence the patient-provider interaction. You'll be able to describe the attributes of a culturally competent healthcare worker and make use of effective communication strategies. And this is at a personal communication level as well as using new technologies. You'll be able to use these strategies to educate clients from different cultures about TB disease, infection, and control. Our faculty today are myself, Sapna Pandya, who works at the Center for Immigrant Health at the New York University School of Medicine, and Jane Moore from the TB Control and Prevention Program of the Virginia Department of Health. The agenda for today is that I'll speak first about the rationale for this seminar and illustrate some of the key concepts about cultural competency and working with diverse populations. Then Sapna Pandya will discuss patient-centered care in a multicultural setting. And Jane Moore will introduce us to some new technologies for communicating with diverse populations. If time permits, and I'm sure it will, I'd like to take 2 or 3 questions after each speaker, and then also allow more time for questions and discussion of all the panelists at the end, so that they can also complete the evaluation. What I'm going to be talking about now are key concepts in working with diverse populations, because in fact there's quite a diversity in all of our clients for tuberculosis. Sometimes we ask ourselves before any course that we start, why do we think this seminar is important? And in fact, we came up with 3 reasons why we felt it was very important. One was that our training needs assessment findings, which came from when we originally started this cycle of funding for the RTMCC, as well as continuing feedback that we get from different key focal points and other people in the different program areas, are that this continues to be a need for new staff coming in and as we encounter new demographics in the populations that are having tuberculosis in our program areas. There are also national and state standards about cultural and linguistically appropriate services in healthcare. And these may have come out a few years ago, and it's taken a while for them to be fully adapted, put into law, put into people's job descriptions, and actually now it's something that people are being held accountable to in their work. And so I think it's trickling down through the health system. Lastly, the epidemiology of tuberculosis among foreign-born persons in the United States, and particularly in the Northeast, which I will show here, it demands that this be a subject that we take very seriously. Here are some selected slides from the surveillance slides for the last year, 2007, the last year that we have complete data. What we see here is that TB case rates by race and ethnicity, we can see that there have been persistently higher rates for Asian and Pacific Islanders, and also other ethnic groups as compared to white Americans. Here is a pie chart which shows that there are large, you can see Asian, African American, Hispanic or Latino. Those are making up the largest proportion of tuberculosis patients, whereas they may not be the largest proportion of the population at large. And most of you are familiar with this chart, which shows that back in 2001, nationwide, the number of foreign-born patients passed the number of U.S.-born patients, and that trend continues. So if you compare the race and ethnicity of U.S.-born patients in that pie chart on the left, you see really a different pattern than you see on the right among foreign-born patients. Among U.S.-born patients, there's a large proportion of Black or African American, whereas that's a smaller group among the foreign-born. Asian and Hispanic predominate among the foreign-born populations. And in all of our programs, we're having to deal with different mixes of this diverse pool of population. This shows here what has happened in the last 10 years. If you look in the dark purple, which means that more than 50% of the tuberculosis cases are among foreign-born persons, you'll see that in 1997, in the area which is the Northeast, that would be the RTMCC, the area that we're covering here. In that area, you'll see many states in which there are fewer than 25, or that there may be 25 to 50% of the TB cases being among foreign-born people. Whereas you look now in the RTMCC, you will see that the largest number of states all along the east are now in the category of more than 50% of tuberculosis patients being foreign-born. The countries of birth of foreign-born persons in the United States with tuberculosis are shown here, and the list has been pretty constant for the last several years, with Mexico, the Philippines, Vietnam, India, China, those countries having the largest number of patients. In each of your program areas, it very well may be other groups or these groups in a different order, certainly. And this is a slide that looks at only the northeastern RTMCC and the 16 states, and I'm including, the Washington, D.C. here. This is the percent of cases among foreign-born persons looking at data from 2007. And I think if you were to look at data for 2006, it would be about like this, and data for 2005, it would be about like this, and data for 2004, about like this. And so what you see is that progressively, there has been an increase each year as we get now to 2007. What I'd like to do now is throw out a polling question to all of you, just to sort of get feedback from you about what percent of your tuberculosis clients are from a culture other than your own. And I would like you to please go ahead and vote. I know we've got 90 or more people here, so I just want to see a bunch of votes come in. If you can use this, just click right on the box that's indicated. We'll leave the polling open for a little while more. I guess I would see, as I look at this now, it does seem like this represents sort of what we're seeing in the northeast part of the country, where the greater number of states are having between 75 and 100% of the TB cases foreign-born. Well, I'll read you the polling results now if you can't see them. Basically, 35% of you who are answering said that 75 to 100% of the TB clients are from a culture other than your own. About 31% were in that 50 to 74% of clients being foreign-born category. And then only about 15 or 16% of you each answered the 25 to 49 or the 0 to 24% category. So what I'd like to ask is, why do we think culture is important? And in fact, there really are many reasons why culture is important. Among them, and you can probably think of more than I am here, but what came to my mind was that really culture can affect many things that have to do with how our programs interact with clients. Just quickly here, the experience of psychological distress, or how people describe their symptoms, that is often driven by culture. People may describe pain differently. They'll say, oh, it's running around up over my back and it makes my head throb and this. Some cultures may be more stoic, and they'll just say, well, yeah, it hurts, and they won't say much. They'll be quiet enough about it. Others are much more willing to just, yell and let everybody else know that they're feeling pain. And I think you have to really be sensitive to each individual, as well as recognize that there are cultural differences in how people may complain about things, whether they present, sort of quietly or just right in your face yelling about things. There's also a difference in help-seeking behavior. That's got to do with whether people go first to a family member, go first to a pharmacy, go first straight to an emergency room or a private doctor. And there have been a few studies on this. In general, what we've seen is that people who are foreign-born may go to a wider range of outlets or sources of information or care. They may go to public health services or private health services in their own country before they came to the United States. They may go to traditional healers. They may go to a pharmacy. They may not have access to care and wander into an emergency room at a awkward time of night. I think they may go to more places before they finally get a diagnosis, whereas U.S.-born people, if they're more connected with the health system, may have a shorter path, fewer visits with providers before their tuberculosis is diagnosed. There's quite a range of ways that people perceive that an illness is caused, or how they think an illness will progress, what you expect of treatment, and how they make decisions about that. And I don't want to generalize, but I have encountered some cultures in which people say, well, in my country, people who had this disease went to a hospital and they were there for 6 months and they only came out when they were pronounced cured. So what is this business about taking medicines and being able to go back to work and us having to tell everybody who we've been breathing in rooms with? There may be distrust or misunderstanding of that. Likewise, with the difference between what infection is, what transmission means, who contacts are, that also can be understood by different cultures. Some cultures may know what being sick means, but the word infection may have other connotations and may sound more dangerous, whereas we know that tuberculosis infection is a latent condition and not transmissible to others. There's also a lot of difference in the names that people use for who their contacts are. Some cultures might call everybody from their own part of the country their brother, their uncle, their cousin. There are many different ways that this will be expressed. Also, depending upon sort of the history of interaction of a group of people with the healthcare system, if in their country healthcare was not accessible, and maybe here it is more so, or if in their country the healthcare system was more exploitative, there may be distrust of the healthcare system, and that certainly will affect the way people interact with the healthcare system, whether they're comfortable following up on appointments, or whether they might feel some shame if they can't make an appointment, so they won't ever call in and tell you. Sort of understanding of how to use the healthcare system may be very different. And all of a people's history really will affect how they behave. Certainly, we can also think that cultures and people are more diverse than just national origin, regional identity, race, or ethnicity. Those are often the ways they get categorized on data that is collected. But in fact, aspects of culture can be defined by or affected by one's gender, religion, economic class, age, language, and experiences in life. There are, and we all come into contact with them every day in our work in tuberculosis, subcultures of people who were defined by sexual orientation, substance use, homelessness, experience in correctional institutions, and any of a number of other experiences. I think that when I see in the newspaper today, the front page of the New York Times had something about tent cities springing up around the country. And I think that we will be seeing new ways in which homeless people are congregating and relating. I think certainly clients of ours who are gay, lesbian, bisexual, or transgender, they also need to be reached out to in ways that are sensitive to them. People who are using substances have been the subject of some of our former seminars, but I think that needs to be also approached with ways in which we connect with local partners who are doing substance treatment programs. Likewise, the place of employment may have its special culture. Lately there's a lot in the news about the way people on Wall Street or AIG think or behave, or the way police do, and we know that institutions like hospitals or correctional facilities or the military have a culture of how they interact. And I think that may carry over into how those people would interact with the health system. Any group of people also have a history, political values, and experiences, often with oppression or discrimination. And how those affect them will really affect whether they trust, whether they approach, and how they listen to healthcare workers. there may be in different groups sort of an opposition to being acculturated, and that's often in response to the way a majority culture would have reacted to them. So I'd like us to reflect on this here, this quote. To be culturally competent doesn't mean that you are an authority on the values and beliefs of every culture. That would be quite a burden. We may be seeing dozens of cultures in our work in tuberculosis. But what being culturally competent means is that you hold a deep respect for cultural differences and you have an eagerness to learn. You're willing to accept that there are many ways of viewing the world. This leads me to, and the philosophy that the Northeastern RTMCC has taken, certainly Lauren Moschetta and others here have espoused it for quite a while, that a culture general approach is what needs to be taken rather than a cultural specific approach. And by that I mean, in what we'll talk about today and what I hope you continue learning about cultural competency and working with diverse populations is broad concepts, principles that you can generalize from and learn from, but validate by asking people questions. We want to focus on you as people who are learning to be more cultural competent, and just an attitude in you of being eager to learn, being open to learning the ways of other people. Whereas if we were to follow just a cultural specific approach, it may lend people to have more like fixed assumption that there are fixed ethnic traits and think that everybody fits in the same box. You may try to just reduce it into a skill of, okay, ask this question and then do this, do this, do this. And it would be like a cookbook. There might be do's and don'ts that you try to apply the same to an older man from a culture as to a child from a culture, or the same as to an educated person from a culture or someone who comes with less education and more of a rural background. Just because they come from another culture, the do's and don'ts are not the same. And it might lead to stereotyping, which is a subject that we'll be talking about later this morning. There are 4 elements of awareness and skills that I would like to point out here. There are some associated questions with each one. But I think that in entering this process of working with diverse cultures, it's important to be aware of yourself, aware of your own values. And then be aware and accepting that there are differences. Think other people don't have to see things exactly the same as you, but you can come to a common ground. Then, with your curiosity to learn about others, it's important that you develop cultural knowledge. Find out about the worldview of other groups with whom you're working. And lastly is a personal skill as well as something that your program can do, and that is adapt the practice skills, adapt the structure of your services to fit the cultural context of the clients that you're serving. And I think we'll see elements of these 4 elements come up in what our next speakers are going to be talking about. Sapna will be going into it more in an individual way, and Jane Moore more in a way of using new technologies. Now, I know we often think that cultural competency is some high value that we will all just go towards automatically. And I think the fact is we go up and down on a given day or with a different type of person or a different context. We may be more unable or blind about things, or we may be more basic or advanced in our skills. And I think as long as we remain open and continue to try to strengthen ourselves in those 4 elements I mentioned before, we will head towards being more culturally competent and able to deal with people from a diverse range of groups. The last message, I know a lot of times people say, well, what can I do? What does it mean to me? Especially clinicians ask this. And I think this quote from Arthur Kleinman is important. If we were to reduce the steps of culturally informed care to one activity, this is something that even the busiest clinician should be able to find time to do. It would be to routinely ask patients, and where it's appropriate, their family members, what matters most to them in the experience of illness and treatment. I think that asking questions is the real key to finding out where people really are and what they need to be able to understand what's next and to be able to work with you. So Before we go into Sapna Pandya's presentation, I would like to throw it open for a couple of questions. Hello, I hear you.
I'm trying to figure out why there is such a big need for diversity as far as the client, because we're trained to be diverse regardless. So we should know going in that you have to be understanding of other people's culture. So why would you need a seminar? Because that would be something that they should already know.
Okay, thank you for asking. I think now most people in programs are aware that this needs to be done, but the personal skills of doing it or new technologies for doing it is why we held this seminar.
Okay.
I think with what Sapna Pandya is going to present, there will be ways of thinking that she will open our minds to, and some tips on how to work with interpreters and others that I think will really be useful. And then in the area of new technologies, from Jane Moore, we'll be getting new ways of working that I think are portable, effective, and sort of enable you to get a standard tuberculosis message across in ways that you probably couldn't at all. So that's the reason for the seminar. Is there another question?
Hi, can you hear me?
Yes, I hear you fine.
I was just wondering, how much extra time do you think that it takes when you start to get into these conversations, or is it a payoff in the long run when you've identified things that matter most to them? Thank you.
Wonderful question. I think sometimes it can be only 3 or 5 minutes of conversation. Other times it can open a floodgate, and you're right. But when you think of the effort that goes into finding somebody who didn't come back or starting medications over again because somebody took them wrong and got side effects and then treatment had to be suspended, I think that the trust and the understanding that if you build it up because you know that person more and understand how they think and why they make decisions the way they do, I think it will save more time. And all the more so because with tuberculosis, we follow people for 6 months if they have disease on DOT treatment, plus there's time in the diagnosis ahead of time. Likewise, people with latent tuberculosis infection, we may follow them for 9 months or more. So if you waste 10 or 5 minutes in early consultations in order to have trust that will last you for months, I think that's a great investment in time. Thanks very much. I do want to make sure that I leave room for all of the other speakers who are here today. I'd like to pass the baton now to Sapna Pandya, who will talk to us about patient-centered care. Sapna Pandya is the Director of Programs for the South Asian Health Initiative at the Center for Immigrant Health, which is part of the Division of Primary Care at NYU School of Medicine. For years, she's been developing innovative ways to train health professionals in patient-centered care, and her interests are really increasing cultural competency and in all of the institutions that she's done trainings in. She also serves to build bridges between newcomer South Asian populations and the healthcare system through community-based participatory research and advocacy and educational projects around general health access and specific disease areas. Her interests are wide. They include health rights within the larger social justice framework, health communication and awareness, and the delivery of care to socially and politically disenfranchised groups. Ms. Pandya also has a background in, and she remains connected to, HIV/AIDS work occurring in South Asia. So I'll now turn the microphone over to Sapna Pandya. Sapna?
Hello and good morning. Welcome to over 100 of you. I'm going to take off from where Bill left off with regards to talking a little bit more about culture, but hoping to open up everyone's minds and as well as my own, I hope with some interaction with regards to culture. And I appreciate the question from before. It's great to know that, some of you, many of you probably already feel like this is something we should just be doing. But, it does serve us well, I think, to take a look at this and also think about not just how are we being culturally competent, but are others being culturally competent with us as well, because it is a two-way street, and we can talk more about that. I want to start a little bit by talking about names. Names are a very interesting thing because I do feel they open up the window sort of to thinking about and talking about people's cultures. For example, if I were to have the roster list of all the attendees of today's conference in front of me, I'm sure by just looking at people's names, I can already start to guess maybe where you're from, what language you speak, what gender you are, all these things I might start assuming, really, and I may be incorrect at that. So I want to start by actually introducing a few different naming systems to talk about that a little bit more as well. My colleague I'll start with, whose name is Javier Gonzalez, and I give this example because his full name, his real name, is Carlos Javier Gonzalez Salazar. There are 4 parts to his name. And you may have seen this as very common in Latin American communities. Javier happens to be from Colombia. The 4 names are just a different definition of a name, right? So whereas here in the United States, it's more common for people to have a first name and a last name, and sometimes a middle name. In other parts of the world, of course, that's not necessarily the same anatomy or the same construction of a name. And it is important to know that for several reasons. Of course, you want to address a person by the name that they would like to be addressed by, just the same as you would want to be addressed by the name you want to be addressed by, but also in terms of maintaining medical records and so on and so forth. On an administrative level, you want to make sure that you have the sort of last name as you would want to call or keep your records of last name and first name straight. So with Javier, the Carlos tells me is there because it's the name of a saint, and so it's not really a name he would go by. Javier is his own given name. Gonzalez is his father's name, and Salazar comes from his mother's side. So really all together, that's how we get Carlos Javier Gonzalez Salazar. All 4 names were used in school and would have been called on the roll call. All 4 names are used on his driving license, etc. So just an example, when he moved to this country, of course, and he met doctors and lawyers and other people that started serving him, he would get information for Mr. Carlos Salazar, for example, which he didn't quite understand because he didn't know who that was. Who's Carlos Salazar? And he had to go through many different hoops in order to maintain his name the way it actually is. I want to also talk a little bit about my name here, which is my full name here, Sapna de la Pandya. And there are actually 3 parts to my name, and it does follow a similar naming structure. I have a given name, I have a middle name, and then I have a last name, which is my family name. So again, the structure is very similar to what you're used to seeing. However, what might be different is that my father's name is my middle name. My father's first name is my middle name, and that is a naming system that is particular to the part of India that my family comes from. And I mention this because, of course, everyone may have different sort of naming structures that way, as well as to where their middle name comes from, if they have one or not, if they use it or not. And with my last name, it starts to give you more information about who I am, actually. Pandya, my last name, suggests what language I speak, suggests what religion I am, suggests what part of India I'm from, suggests even if I'm vegetarian or non-vegetarian. Actually, all of that is information that's embedded in my name. And if I encounter somebody from the same part of the world as me, they typically can tell just by looking at my last name, though often their assumption is incorrect, especially because Pandya is a vegetarian last name, as it were. So a lot of times at social functions and social gatherings, the non-vegetarian dishes will get passed right by me, and I'll have to call it back because I, as an individual, happen to eat meat, even if my name suggests otherwise. So that kind of gives me also an opportunity to say that though names suggest something about someone, it could be an incorrect assumption as well, and we do need to keep that in mind, and that's why, again, going back to Bill's point, asking someone, rather than assuming sort of what is your name. And lastly, I want to mention my colleague Wendy, whose family came from China, and often in China and in other parts of Asia, you may have somebody's last name, what we call last name, or in other words, their family name, actually appearing first, and then their given name coming after that. And that was the case with Wendy, although Wendy happened to change her name around and put the Zhang, her family name, afterwards, though it appeared first when she first came here to the United States. And then she has a Chinese name as well as an American name, and uses both. But you may encounter patients and clients that have not switched their name around, and so you may want to ask them again for maintenance of your records, as well as asking them and referring to them by their name, who are you, and asking how they would like to be addressed. So that's just a little bit about names that hopefully opens up the discussion to other points. But you may encounter patients and clients that have not switched their name around, and so you may want to ask them again for maintenance of your records, as well as asking them and referring to them by their name, who are you, and asking how they would like to be addressed. So that's just a little bit about names that hopefully opens up the discussion to other points. I want to take a second now and actually go through this. What are generalizations? What are stereotypes? And what is cultural competence? And these are all terms that have already been referred to before, so I'm not going to spend a lot of time on them, but just something to think about as we go through this exercise, which is I'm going to actually ask you all, if you would, at your desks or wherever you are on taking this call, on a little piece of paper, if you can jot down your responses, because with this number of attendees, we can't actually take responses from everyone. If you can jot down on a piece of paper, and I'll trust you to that, your answers. As I go through and show you these pictures, think about where you think they're from, and if you could, and if you have a guess why you think that is. If you see a person's picture and you think let's say you think they're from California, why do you think they're from California? What is it about their photograph? If you think they're from Italy, why do you think so? So I'm going to go through and show a bunch of pictures. I'll pause for a second to give you guys a chance to write it down, and then I'll go through again and give you the right answers once we've gone through all the pictures. So this is actually the first one, and I would encourage you to look at everything you can to help yourself develop a guess about where you think they're from and why. Facial features, hair, the body art. This person is the next one. If you can quickly jot down where you think that they're from. Again, I encourage you to look at the same features again in terms of helping you come up with where are they from and why. I'm going to go on. In this slide, the person that I'm actually, interested in you all looking at is this one here, the one on the left, and you can take a look at all the various features. The reason the other two are there is kind of a hint because of a famous person. So. Here's the next slide. Okay, you might have guesses looking at her, where you think she's from. And this is the next one here. Okay. Again, eye color, hair color, skin color, dress, jewelry, etc. All these various things usually inform our guesses. And the next one, this usually is a bit shocking to look at. I have been told that's his real hair. And this is the next one here. Again, think about what he does for a living, if you can tell from the picture. And one more. Again, if you just jot down where you think they're from. Or even what word you would use to describe each of these people. And then this is the last one. Okay, so since we're doing this on a call, I'm going to have to assume that everyone's done and has jotted down or thought about their responses as to where they think they're from, and I'm going to go through each of these again now, because there is actually one community that I could say all these people belong to. And it is a term that's used to define people from a particular part of the world, which in and of itself is very diverse, but yet we do use this term. And that is that you may have guessed all over the world in terms of where you think people are from, but actually every person I've shown you is from Latin America. Every picture that I've shown you is of somebody that we could define as Latino or belonging to the Latin American community. So there are many different, obviously, facial characteristics and dress and all kinds of things that even belong to this subgroup. And I could have done this with really any community. I just happen to have these pictures to share with you today because the same would have held true for any other community I would have picked as well. This person is actually a singer from Colombia, and she's a bit famous in Colombia as well, as is this individual. He's also a singer, a pop singer from Colombia. A lot of times people say that they think he's from Colombia because they think that his hair and his stance and all of that. So it's interesting, even body language makes us think something about where we think this person has come from. And actually, a lot of times people are also confused about his gender. People do think that this is a woman rather than a man. So gender also is assumed by people's physical characteristics. This is the next one. As I had mentioned to you, a famous person. The one on the left is actually the son of the famous person who's in the middle, is Gabriel Garcia Marquez. And, so we have actually another person from Colombia. And a lot of times people think that he's from London or, Europe, largely because of the collared shirt and the sweater and the hair, and again, the hat on his father's head. So a lot of these things also give us clues, so to speak, about where someone's from. This person is actually from Argentina, former coworker of mine, but a lot of times people think that she's from Eastern Europe because of her hair color and her eye color. And this person is from Nicaragua in Central America. And this person, a lot of times people think he's from Brazil. He's actually a soccer player from Colombia. And he's a race car driver from Colombia. And a lot of times people think he's Italian. I also get sometimes Indian or South Asian. Again, skin color can suggest many different ethnicities or races as well. And this individual is actually a sportscaster from Colombia. He's, again, well known. And the person before and this person are both also part of another subculture. And as Bill mentioned, we can talk about cultures in different ways. They're part of a sports subculture. And if you belong to the sports industry or the sports world, you might be of that. And she's actually from Bolivia. So, again, everyone being from Latin America, but a lot of times for her, for example, people think she's from Eastern Europe or Russia. I get a lot as well. So that kind of gets us into this whole thing of generalizing and stereotyping. And, of course, what is generalizing and stereotyping? And is there a difference? We use these terms interchangeably quite a bit, but if I were to give you an example, saying something like, all the chairs in the room are uncomfortable. Let's say you walk into a room and you sit in one chair, and afterwards you make a statement, all the chairs in this room are uncomfortable. That would be classified really more as a generalization because, of course, you've used the word all and a characteristic to define really the entire community of chairs, so to speak, the population of chairs. And that comes from an experience you've had with one member of that community. The one chair has defined the characteristic that they all share in your mind. And that's common. That's a very, very common thing to do. And it might be a little different from then the next time walking into the room and sitting in a different chair. Okay, this is a chair you have not sat in before, sitting in a different chair and thinking to yourself, oh, this chair must be uncomfortable because it's a chair in this room, and I know all the chairs in this room are uncomfortable. That is when we're stereotyping, and we're sort of assuming that just because that chair is also a chair, that means that it must be uncomfortable like the other chair that you had the experience with. So, of course, you know, we can see the connection to how we do this with human beings as well and with cultures and with populations. And, of course, you know, I know that we all know, but I do also want to mention that sometimes we use stereotyping and generalizing in what seems to be even a positive sense, as in, you know, we might say something like, this community, I'm sure that there must not be, you know, TB in this community because we know that it belongs to certain communities, or I know that there must not be substance use, or there must not be drug abuse, or et cetera, happening in this community because there are positive stereotypes we might apply to that particular community as well, and to members from that community. A lot of times with women, for example, you know, it's natural to assume that a woman might not be at risk for something. I know, for example, Asian women are the least tested for HIV for a couple of reasons. A, because they themselves may not consider themselves at risk, and B, because also their providers may not assume that they might be at risk, and so therefore don't suggest an HIV test. So just to keep in mind, again, stereotyping, how we use these social categories to recall information, just like we recalled the information, whether it was false or not, that all the chairs are uncomfortable. And then generalizing is, of course, making that statement based on a common trend or occurrence. So just a way of looking at this, a way of sort of thinking about generalizing and stereotyping, textbook definition-wise, as well as that example that I offered. And, of course, it goes without saying to be careful to avoid this. I'm not going to spend too much time talking about cultural competence because we've already defined it. I just want to remind us that there is also, besides the idea that it's going to save time or save resources in the future, or that it's going to be delivering better care to our patients, and those two being very compelling reasons, of course, for the push to be culturally competent. Also, there are laws and policies that we have that will sort of define the need for or the requirement to be culturally competent. For example, the Civil Rights Act of '64 says that any program that gets federal money cannot discriminate against a person on the basis of race, color, or national origin. And so, you know, this is, again, something to kind of keep in mind, that race, color, national origin, when I say that, part of national origin is also language, and the language someone is speaking. And there was a recent executive order passed in 2000 that expanded on the Civil Rights Act that said explicitly that national origin also includes language. So therefore, federal programs or programs receiving federal money cannot discriminate based on race, color, national origin, including language. And again, this is a repetitive from before, but just to say that there are big sort of cultures that we look at, as well as the microcultures of sexual orientation, disability, religion, gender, age. And the main one left off of this slide, which I would really like to focus on, is class, in particular because it is the most often overlooked culture in the United States. And that really does define where one lives, what access to medicine does somebody have, how do they dress, what kind of work are they doing, how often are they working, and all of these things, as we know, have an impact on someone's health and also health-seeking behavior. So two people could be perhaps from the same racial group, let's say, but they could be of completely different socioeconomic classes, and that's an important thing to keep in mind. I want to give you an example of one of these microcultures and how it might make an impact and how we might look at religion, in particular, on faith or the practice of religion to care effectively for patients. And there's several ways in which this could make an impact. I've just picked a few here. For example, based on somebody's faith or religious community, there might be dietary laws that they are following. For example, they may be vegetarian, or they may be kosher or halal, which following kosher or halal, which are dietary laws. Kosher for the Jewish community, halal for the Muslim community, are very, very similar in terms of the laws and the restrictions against eating certain foods, in particular, for example, eating pork meat or pig meat. And there are things we use in a medical setting that could be considered non-kosher or non-halal. For example, gelatin being made from substance found in pigs and horses, is non-kosher and non-halal and also non-vegetarian for that matter. So it's just important to know sort of what are the dietary laws of the different individuals that you're working with, and maybe not assuming as well that just because they're from a particular religious community that they do have that dietary law, that they're following that. Hot and cold foods refers to basically an overarching philosophy about food that is found a lot in some Asian cultures, but is found, I've seen, in other cultures around the world as well. So I don't want to generalize about one particular part of the world. Hot and cold food is really just about sort of the balance, that one might look for in terms of maintaining one's diet, because in many communities, and by many people, I should say, health is considered more of a balance or equilibrium state, whereas disease is considered off balance. And so therefore, in order to maintain that balance, you might have foods that are considered hot or foods that are considered cold to maintain that equilibrium or balance. And by hot and cold also, I don't necessarily just mean temperature. Some people consider, for example, non-vegetarian food a hot food. It'll throw you off balance, for example. So just some dietary laws. And again, these are questions you can ask your patient or client directly rather than sort of trying to become an expert in all the various types of laws, and asking what their restrictions are, what are they following, and, if you have time, why. And a few other points here, clothing and modesty as well. And I mentioned that because in many different communities, in particular, if one is practicing in a more usually orthodox way, then you might have varying levels of modesty, especially in a place of worship. And what I mean by this is, of course, in terms of dress. And, one wouldn't wear something revealing or very casual in a place of worship. And, that just goes to show that when you also do health fairs or outreach in places of worship, that is maybe not the way that someone is dressing outside. It may just be how they're dressing in that place. And also modesty in terms of behavior. We've done in some of our outreach, some of our clients, we have actually tested at places of worship. And when we do our TB testing and ask them the background questions, have you ever used substances? Do you currently use substances? Do you drink alcohol, etc.? These are questions that one may not actually answer honestly while you're sitting in the house of God. And so therefore you have people that might say, no, of course I never drink, or I never take drugs, or etc. And if you encounter that same individual elsewhere outside the place of worship, you might get different answers. So that is something to keep in mind. Also, the observance of certain holidays might influence care, especially in holidays where somebody's diet or other behaviors are altered for a specific period of time. And I'm thinking of, for example, during Lent or Passover or Sabbath or Ramadan. These are all sort of times on which on Sabbath, for example, some individuals may not use electricity, therefore may not use the nurse call button, and you may have to come up with another solution for how that patient can get in touch with the nurses, or may not use the electric button to open doors as well on Sabbath. During Ramadan, people who are observing Ramadan, Muslims who observe Ramadan, will fast from sunrise to sunset, and many also abstain from drinking water during that time. And, according to religious law, and I don't want to get too much into this, but religious leaders may tell you that during Ramadan, if you are sick, or if you are on medicines, or if you're pregnant, or if you are a woman and menstruating or traveling, you are not to keep that fast. You're not supposed to keep that fast during that time. However, the reality is that there are people that do observe that fast during Ramadan, even if they are sick or pregnant or traveling. And, I'm not suggesting that you tell them, well, you shouldn't be fasting, but rather, how do we then work around that? Because I know if patients are not drinking water, they may not be taking their TB meds during the day. And so then we do have to come up with some other way of, for example, with DOT, come up with some other way of making sure that they are taking their medicine. If maybe the time has to be altered during that month when Ramadan is being observed, so that it happens before sunrise or after sunset. And that might involve using community-based organizations or faith-based organizations in the area that you live in, getting in touch with local Muslim organizations and seeing if there is someone that can help you make inroads with that patient, or if they have someone that can serve as a monitor for DOT, or if you can get someone in the family to do that as well. I know in some cases that's been done, is using family members as well. In many Muslim countries, that is what's done in terms of TB control. So just a few examples, again, and if I picked every other microculture, we would be here all day talking about all of those things. So I want to move on and talk a little bit, being mindful of time, with regards to barriers to accessing care. We've already talked about some of those. Linguistic barriers, financial barriers, of course, are huge. Geographic. Is the patient wanting to go very close to their home to access care? Or on the flip side, sometimes patients actually want to go to a clinic that's far away from home because you don't want folks to know that you are getting treated for TB or getting treated for HIV or other diseases that we have social stigma around. So therefore, you might have patients actually traveling long distances simply to get away from the community that they live in. Legal barriers as well with regards to immigration especially, and the types of programs that immigrant patients, for example, may or may not be eligible for. For undocumented immigrant patients, there are many federal programs that they are not eligible for example, Medicaid, and so that poses a huge barrier with regards to getting their care financed. And while emergency Medicaid might be an option, it's limited in its coverage, and it really covers only emergency situations. I also just, very quickly want to talk about how does one get a green card. And some of you, of course, may already know this very well and personally, but just in terms of talking with the immigrant community, just to mention this, that the general sort of way that one would follow is that you get your visa, and then you get your green card, and then you become an American citizen. And I'm oversimplifying it. But just to mention a few different ways, of course, we know through family and work and through heterosexual marriage are ways that one can get a green card. I do want to also mention that there have been adjustments to refugee and asylee status. What I mean by that is that there are individuals that can ask for asylum, as in can they remain in the United States because conditions in their home country are too dangerous to return to, or refugee status where conditions in their home country are too dangerous, and so therefore the United States has said, okay, from X country we will take 5,000 people to come and move to the United States. There are other conditions that have been included in that, and I want to mention that specifically to you all because some of those include, for example, HIV status as well as sexual orientation. There have been adjustments made where lawyers, public interest lawyers especially, have been helpful in arguing that if an immigrant patient, for example, is gay and in their home country they would be criminalized or they would be so stigmatized, then they should be able to remain in this country seeking asylum in this country. And I know of a few cases where that has been successful, where someone has been able to stay because conditions are too dangerous for them based on being gay or lesbian or transgender or bisexual. The same goes for HIV as well, that if one is HIV positive and in their home country they would not get access to medicine, or they would be so stigmatized against, then that is also a way that one might be able to say, asylum is really based on persecution. One might be able to say, well, I would be persecuted in my home country being HIV positive, and I therefore need to remain in this country. I also want to mention the Violence Against Women Act, and that was introduced in the 90s by Janet Reno, and that was actually specifically for immigrant women who are, tied to their husband's immigration status. So, for example, if a husband comes over on a work visa, let's say, he's allowed to bring his wife over to work. Not to work, sorry. He can work. She cannot work. She can live here, but she cannot actually earn money. So what that actually produces is even more of a power imbalance. What I mean by that is that she's not only dependent on him for money because he's working and she's not, she's also dependent on him for her immigration status. And unfortunately, when there's abuse happening in that situation, and this has happened quite often, he can say to her, look, if you tell anyone I'm abusing you, I'll have you sent back home. And so therefore she doesn't come forward. The Violence Against Women Act protects against that. Of course, it still takes a lot of emotional power, empowerment, et cetera, to be able to come forward and say, look, I'm in this situation where my immigration is tied to my husband and I need to remain in this country. But one can reference the Violence Against Women Act to help such patients. And that kind of takes me to talking about immigrant concerns. And as you can see on this chart, and I'm going to wrap up very quickly, health falls then to the bottom. When one is so concerned about things like putting food on the table, public charge, which is the use of public benefits, for example, government hospitals or Medicaid, and how that might influence them when they're applying for their green card, confidentiality, having to support family members back home. Most immigrants are also supporting not only themselves here and their families here, but also their families in their home countries. And while they're concerned with all of that, health and their own health in particular can fall by the wayside. I also want to just mention quickly, as Bill said, that that working with interpreters is an important skill to develop further. And this is really just the tip of the iceberg. But we do know that one should ask first, would you like an interpreter? Can we make an interpreter available to you? And whether that's an in-person interpreter that you have in your facility or whether it's using the phone line, you can ask that question first. And then if they're not available, then you might have to professionalize an ad hoc interpreter, or you might have to take an ad hoc interpreter if the patient insists on that, on having their family member, for example, interpret instead. So a few things to keep in mind. Tell that person no omissions, no additions, no substitutions. In other words, tell the patient everything I'm saying and ask the patient to tell the patient everything that I'm saying, and also tell the doctor or the provider everything that the patient is saying. So that is that point. And also asking for clarification. What that means is if you have someone who's not trained to be an interpreter, they may not actually know the health terms, the medical terms that are being used, and may be shy to ask you that. So you want to just open up the door and tell that person that, look, if there are any medical terms that I'm using that you're not familiar with, ask me and I can let you know what they mean, and maybe you can use other words to define that term for your patient as well. So like I said, very much tip of the iceberg here, but there are many issues to consider: positioning, eye contact, and so many other things to make the interpreting experience even better for your patient and also for you. So lastly, I just want to say that there are some questions that summarize the things that Bill and I have talked about: how to get to know the individual. How did you travel here today? In addition to the things like, how do you prefer to be addressed and what country did you grow up in? Are you comfortable reading? Are you more comfortable reading in your language or in English? Because actually you might assume that someone, just because they speak another language, might be more comfortable reading in that language, but that may not actually be the case. And also, are there certain procedures and tests which your culture prohibits is also an important thing to ask people. Which populations are predominantly represented in your program is something to consider on a program level. What is the perception of health and illness in the community, and the relationship between providers in the community as well are all questions to look at in one's program. Just a few points I want to highlight. One is that hiring bicultural and bilingual staff is very important in terms of matching your client needs. And you can look at that, of course, as making the experience better for your patients, but in the end, it was going to help you also as a provider as well to have bicultural and bilingual staff on hand. And it really is a payoff in the long run so that we don't have misdiagnosis or unnecessary testing, or down the line malpractice litigation, which can be much more expensive. And also, as I mentioned with the example in Ramadan, is working with community-based groups. And that is a very important point, I believe, in really helping, because if you don't have, and I know we all work with limited resources, if one doesn't have the staff on hand, then asking community-based groups about the patients that you're working with can actually increase your resources and increase the actual human power that you do have within the facility that you're working in. So I want to pause now because I know that there's only a little time left and take some questions or comments for a couple minutes before we go on.
Thank you, Sapna. This has really been interesting, fascinating exploration of naming systems, stereotypes, and working with interpreters. It's really a lot for us to think about, and you've really pointed out many ways in which we can go about developing our own skills in cultural competency to be better able to work with diverse populations. Now, I would like to throw it open for questions from anyone who is calling.
Hello, may I ask a question?
Yes, please.
Of course.
I'm back on the part where you talked about class, and underneath was a green card, family member, employment, marriage, lottery. What does the term through investment refer to?
Very good question. That's actually a very small category of people, but there is a way that, to be very sort of blunt about it, you can buy a green card in the sense that but that actually is if you have a lot of money. You have to show, I don't remember exactly what the dollar amount is, but basically you have to show that you can support 10 individuals also as employees. So it's only really very wealthy people that can afford to do that, and it's extremely rare. In the last sort of 5-6 years, I think I've only heard of one person that has ever gotten a green card through investment. Any other questions?
Along the same vein, what does the term rendering tone mean when you're talking about translators?
That's an excellent question. Thank you for bringing that up. Rendering tone refers to, let's say you were listening to a language that you didn't know that you were not proficient in. It's difficult to know from just hearing somebody's voice what the tone is of that person, what the emotion is that they're trying to convey. If you listen to someone speaking English, like for example on the phone, you can usually tell, is that person happy, are they sad, are they anxious, are they perplexed, are they confused about a situation? All of that is actually embedded within the language. However, if you don't know the language, it's not there. So when you have someone who's an interpreter, you want them to also be able to render the tone of that language when they're interpreting. So for example, if someone sounds very sort of sad and depressed in Spanish, you don't want your interpreter to sound happy and chirpy, and you would never be able to tell if you don't speak Spanish what actually is going on. And of course, body language can give you some clues, but it's not always enough. So what we do when we train interpreters is that we train them in how to render tone, basically being an actor. But if somebody is untrained, then we just ask them, if you can try to render the tone when you're actually speaking in English to me, or if you can just at least tell me what is the tone in her voice or what is the tone in his voice, so that kind of helps the provider also figure out what is the patient feeling. I'm sure some of you may know of training courses for interpreters that are out there, and I do encourage you. There is no sort of national certification for interpreters as such, but there are a lot of training programs for bilingual individuals to be interpreters in medical settings. And I do encourage all of you that can do that are bilingual, to be trained as interpreters, or to have your bilingual staff trained as interpreters as well, because they will learn these various rules.
Hello, can I ask a question?
Yes, please.
Yes, I am Omar from Atlanta, and thank you, both of you, for your presentation about serving the diverse population. It's a comment and a question. In the culture where I come from, it's very difficult to differentiate between pain and fever. A person may say that they have a pain on their head, or a pain on, and it will be very difficult to say whether they really mean that their temperature is high or they have an actually pain. So I don't know if you ever met particularly, Somali speaking or East African speaking people. And the other point and question is that a lady may come to you and say to you that I have headache in the morning, or I have back pain, and which many times implies early pregnancy. And unless somebody is culturally competent, you may, give Motrin or something for the pain, unless you ask a specific question. So I don't know if you ever encountered these situations. Thank you.
I've encountered very similar situations, and actually we have a similar phrase in South Asia, in some South Asian regional languages, where you say, I have a pain in my heart, but it doesn't literally mean that you have a pain in your heart. It might just mean that you're sad, or that you're feeling sad, and it just gets translated that way, as I have a pain in my heart. And, sort of some things like that, for example, are expressed in different ways, and I really appreciate you bringing that up, and also the part about the pregnant woman, because we do need to figure out different ways of asking questions, and that's why maybe not just taking it at face value when somebody says something about what they're feeling, but asking other questions. Are there other things that you're experiencing? What other needs do you have, et cetera, et cetera. Just figuring out a way to kind of ask questions in different ways also so that we get the information that might be missing if we just take the words at face value. So I do appreciate that.
Jane joined the Virginia Department of Health Division of TB Control in February 2002 as the nurse consultant, and she became the assistant director of the Virginia TB program in 2006. Prior to coming to tuberculosis control, she was the TB and communicable disease coordinator for the Alexandria Health District in Alexandria, Virginia, for 10 years. She's been with the Virginia Department of Health since 1988, and she received her bachelor's in nursing from the Medical College of Virginia, Virginia Commonwealth University, and she has a master's in health services administration from George Washington University. She's an affiliate member of the American Thoracic Society and a member of the National TB Controllers Association. She's past president of the National TB Nurse Coalition. She was named Virginia Department of Health Public Health Nurse in 2001. And what she's got for us are some exciting new ways to use technology to improve communication with a diverse range of clients that you may not have been thinking of yet. Jane?
Good morning. It's nice to join you all. We're going to talk about a project we've had going on here in Virginia for a number of years, and it continues to expand. From many of the different things you've heard from both Bill and Sapna this morning, you can tell that when you're dealing with people from countries and cultures around the world, that communicating the TB message still remains an issue in many of our TB clinics. And I'm going to first give you a little snapshot of what it's like in Virginia, and then we're going to go on to what has become part of our strategy in providing care and education to these people and populations. TB in Virginia, last year in 2008, we had 292 cases for a rate of 3.8 per 100,000. We were down a little bit in our percentage of foreign-born, but we've had 72.6% of our cases last year were among the foreign-born, and you can see the year before we were almost at 75%. In 2007, what that represented was 42 countries and speaking 18 different languages. And if we look over the last several years, that has consistently ranged in, we've had anywhere from 40 to 45 countries represented in our caseload and different numbers of languages, somewhere in the high teens. Virginia passed where U.S.-born, became the minority of our caseload in 2000, a little bit earlier than Bill described that the U.S. did. And as you can see, the number of foreign-born cases has been on a rise, and the number of U.S.-born cases has come down over time, although we did drop just slightly in our foreign-born cases this year. Our top 5 countries look slightly different. Many of them are the same, India, Philippines, and Mexico, but we're a little unique in our top 5 countries that we're looking at Ethiopia and Honduras. So how this project started was a number of years ago that the Virginia Department of Health recognized that we needed some TB education materials for our clients, and the task of producing this was undertaken by our Patient Education Committee of our Virginia Department of Health Nursing Council. We met for a number of weeks with that committee, members of the TB control program as well, and we developed 7 pamphlets that you see the topics described here, or the titles. Initially, these materials were translated into 9 different languages. When we finished producing the set of 7 different pamphlets, I was asked how we wanted them printed, and I said, we don't really want them printed. We really need them translated, because if you look, not too many of our patients speak English. And I said, I think our money is better spent on translating these materials so that they're more useful to us. And thus, having them translated, launching them on websites so they could be downloaded by nurses in all our health districts across the state became our beginning of our web-based solution to patient education, because they can be downloaded, each language and topic, on a just-in-time kind of situation. The language decisions for which languages we were going to produce were based on analysis of our morbidity and also consultations with our newcomer health program of looking at groups that were planned coming into the country. And our original versions only covered print versions. And when we looked at this and began using the materials, we did discover that while we thought we were pretty smart having something that we could give to somebody in their own language, many of our patients were illiterate in their own language and could not read the materials. About time we were figuring this out, an opportunity presented itself, and we received contact from Dr. Mary Alice Gillespie of Healthy Roads Media, and she had discovered our materials on the website, wanted to partner with us to apply for a grant to turn these materials into different formats for use. Those initially were a reformatted print version, a multimedia version that we're hoping to demonstrate to you in a few minutes, and audio versions. Our initial venture into this, we only did 4 languages, English, Spanish, Vietnamese, and Somali. And our concept was to look at, along the lines of what Bill was talking about earlier, having these materials be cultural neutral. So they weren't aimed at any one ethnic group, any one culture, any one country, that they were really sort of, once we had the general format for the materials themselves, that the material could be translated over and over in different languages, but the concept remained the same, the graphics, a lot of the formatting remained the same. We did obtain a grant from the Greater Midwest region of the National Network of Libraries of Medicine, which supported our project and supported our translations and development of the materials in the initial 4 languages. We have additionally had additional funding that has expanded the total languages available into 9 now. And while we only had some limited formats, I'm going to show you how this has been expanded to include web video and mobile. This is just some examples of the many cultural neutral images that are used, and you're probably looking at them and say, oh, some of them look kind of cultural to me. But what you'll see when we look at some additional things is all of these graphics will be used in a presentation, or many of them over and over, and it doesn't matter what language or culture you're aiming to reach through when you're using the materials. You will see many different races, many different ethnic groups, different sexes, many different peoples, and even like the world, that there'll be sort of just sort of a graphic. We have used these in a variety of teaching options. We can use these one-on-one in a home or clinic situation where you have a laptop or a computer set up. We have had DVDs and DVD players that we've used in waiting rooms. The audio versions have been downloaded onto MP3 players or iPods, and they can be used either alone or in conjunction with the print version. And recently the materials have been formatted so they'll work on some of the iPhones or some of these new mobile phones that can download things and play them and play television programs, and you can actually download them onto the mobile phone when you're making home visits or out in the field and play whatever you want right there on a small screen in front of the patient. This is an example of an encounter where we are seeing a person with the print version here being seen, and also they're playing it into the MP3 player. Just some practical facts. You're probably wondering about this, and the most important thing you need to know is that everything I'm talking about and going to show you, with one exception, is free of charge. They're on several different websites that I'm going to have links for you in a moment, and they are free. You can download them, save them to your computer, save them to CDs, save them to DVDs. Anywhere you want to save them, you can show them and use them. Recently, Healthy Roads has taken the materials and downloaded them into a format appropriate for closed-circuit TV if you wanted to show them on sort of a continual running loop in some sort of waiting room in a hospital or large clinic situation, and they do provide this for a small fee. The runtime varies with topic and language. The shortest is a little under 2 minutes, and some of the longer topics with some of the languages that tend to have more words to say what needs to be said, that they can go over 6 minutes. And for every version, there's an option to print at the end of the presentation. Looking at things over the last 6 months, we've looked at our web data, and we've had, obviously, The United States is the most downloading country, but we've had hits from 55 to 64 countries each month looking at it over the last 6 months, and these are sort of the top 10 countries that have come and used the materials that we have on the website. English remains the most downloaded, but you can see the ones that are being picked up off of our website. It was interesting to me that we tend to think of the Spanish population or Spanish-speaking population as the one we encounter most, I think, a lot of the time, and it didn't make our top list here of languages that were downloaded. These are the most downloaded topics. And this, when you go either to the Healthy Roads Media or you go to the Virginia Department of Health website and click on the link to our link to our patient education materials in multimedia formats, this is where you are taken. When you get here, you have several choices, one of which is you can pick the language you want to see, you can pick the formats you want to see, or if we were to scroll further down here, you'd see a list of topics. Once you get to the topic you want to see, you can then see which language and go ahead and select which format you would want to see. And they're all listed. You can pick whichever version you would want. For this shot, I chose looking at Somali. It does tell you that there's other languages available, and it, again, allows you to look at formats. What I couldn't show you earlier, it begins a bunch of topics, and if you're looking for health education other than tuberculosis, there are a wide range of topics that you can provide cultural neutral health information for people. And this actually shows a little bit this here, but if you will want to listen to this program, you would pick whatever format. When you look, not all formats are available in every topic or language, but it'll show what is available for what you're seeing here. So the initial screen comes up like this, and then the program starts. To actually, very much like a recorder, and to actually make the program run, you would press the button right here to see it run. This is a control that will, right here, that will adjust the audio. And also, if you ever want to stop the program here, you would click the stop button right here. There's information up here about how you can share these materials, and I'm going to show you something about that in a minute, that these are all done with a Creative Commons deed, and you can read this at your leisure later when you go to the website and look at these for yourself. But I wanted to show you that these actually has a big red box warning down here to please copy and share these materials widely. So they are free to you and free to go on and do that as you would like to. Once you get into a program, each screen will come up as the program is advancing and give you some text that the content is being actually read to the client. It'll show you one of our pictures that will vary. Again, like a recorder, this will either stop or start based on where you are. You can advance or retreat to the next slide, advance all the way to the end, or this will take you back to the first screen, this one that I just showed you. I want to actually point this box out up here where it says click here for English text, and if I go on to the next slide, every slide has the ability of a small box in that area where you can click and actually see the English text of what is being presented in written form to the client and actually what is being presented verbally to them. Again, on each slide, the screens remain the same. A couple more examples of the images that you'll see throughout the various presentations. And at the end, there's always an option to print. Now, just so you know, this is always yes and this is always no. In order to finish the program, you actually, if you don't want to print, but actually to finish, you do have to actually press the no. Or yes, if you are connected to a printer and can actually do that and want that. Web video will come up and look very much the same. However, once you get into the program, the screen looks a little bit different. Again, it gives you the option of knowing there are various formats instead of the one you're looking at, if that would be more sufficient. The screen, as you can see, is slightly smaller. Again, though, we have the start, the pause, the stop. This will tell you your run time, and right down here can allow you to change your audio. I think I forgot to push the button. This is the run time area, and of course the run, pause, and stop. Same basic format, though. We have text and we have a graphic. Just another shot of the web video. Print versions, they're all formatted to print off on one page. Our original materials were trifold and had fronts and back, but this is all one-sided, one page, so it takes a lot of the guesswork out of printing, and you don't have to do anything too remarkably other than hint that you want a print copy. I think I've mentioned that we do have other formats. I'm not able to demonstrate those, but they will come up on your computer when you try them at the website. A little visual here of all the different kinds of technology you can use to run the various formats of this program. And these are links about where you can find it. This is directly to the Healthy Roads material. This will get you to all of our 15 pamphlets in 15 languages and also provide a link back to the Healthy Roads material.
Jane, thanks so much for sharing these methods and materials that you've been using. Through the Internet, this is available to all of us, so any of your program areas can take advantage of it. It's really an exciting example of a successful public and private sector collaboration in an area that I think can really have a tremendous impact to reach clients that we're not really reaching with accurate information. Now, like many innovations, it takes insight and creativity to work out all the details, and I'm glad you and your program have done it for us. Now, what we need is access, and we can just run with it. So let me ask you, let's take a couple of questions for Jane. I think we definitely need to do that before we wrap things up.
I have a question. Please? Can you hear me?
Yep.
To what extent, if any, are you using webcams for DOT and for providing information going both ways?
We don't use webcams for DOT in Virginia very often. We do have a few of our jurisdictions who have purchased a video cam and have used that. They are finding that they have to use it with very select patients that are carefully screened to make it successful.
Are there any cultural barriers specific to the use of webcams that anyone's aware of?
The one county in particular that's been using it probably has 90 to 95% of their cases are foreign-born. So they have used it with people of different cultures. Sometimes it's more of a monetary issue that the person has to have a phone that they can hook this up to rather than it being a cultural barrier. It's more of a financial barrier.
I think in some ways this can enable communication when culture would be a barrier. I know a health worker in New York City who has a family where he does video DOT, and the family says, we would not be comfortable with you coming in our house every day. But with this by the phone, we're really happy to do it. So in that sense, it's working.
I did want to remind everybody that the materials that were demonstrated to you are, Bill said they were widely available to you on the Internet, and they are free of charge. There's not too many times where somebody says that something is free for your taking.
Hi, this is Elizabeth from Alexandria. Are there any statistics on this video DOT that it's been successful or what? Thank you.
This is Bill. I guess if you email me, I'll give you my email address here later, I can get you in touch with people who have done pilot tests of that in New York City and New York State. However, I'm sure that there are many other pilots going on around the country, and we'll get the answers for you. I don't have it right now. Are there any questions for any of the panelists today? Speak up.
I could make a comment.
Please do.
As far as the availability of a phone line, it seems like it would be possible to provide a family even with a cell phone, and that would enable them to perhaps use some of this technology.
Good point, Jane. Has your program ever considered that?
We have actually provided patients cell phones for communication back and forth. However, the one county that has purchased their video phones, the technology that they purchased is not usable with cell phones at this time. It does require a landline. We have been exploring some of the webcam situations for patients but again, that does require them to have Internet access, but we are exploring those options.
Well, I'm sorry, that's all the time that we've allotted for the seminar today, and I really thank so many of you for staying beyond the noon hour. If you have additional questions, please feel free to email them to us. My email address is right here. We'll be happy to address them or forward them to other presenters in order to get you the answers that you need. I want to thank very much our faculty today for sharing your knowledge and experience. It's been fascinating for me, and I hope you've learned from it too. And thank you to all of you, the participants, for your questions, input, and discussion. And just to remind you, there are background documents which are included in the list of resources. Also, if you go to www.findtbresources.org, then you can find the Cultural Competency Subcommittee of the Education and Training Network, find their resource guide, and that can lead you to a wide number of useful resources. There are many upcoming courses for all of you in the Northeastern region, and you see them listed here. You can also just go to the website, www.umdnj.edu/globaltb, and find out about other training courses which are coming up in the next weeks. A reminder that medical consultation services are provided by the Global TB Institute. You just call 1-800-4TB-DOC, and any question that you have that needs medical consultation, we'll get back to you with the answer. This concludes the conference, and I thank you very much for your participation. We look forward to others in the future. Goodbye.